So for a patient with newly diagnosed metastatic prostate cancer, first and foremost, I generally like to get a sense of what their understanding is of the current state of the disease. Usually they're referred by a urologist, sometimes their primary care physician, sometimes a radiation oncologist, and it can be quite variable, or sometimes even post-hospitalization where they might have presented with a pain crisis or urinary obstruction or something else like this. And it's quite variable how much information they've been provided, as well as how much they've retained, especially if someone has just been diagnosed, they've been flooded with a lot of information, incredibly overwhelming. So getting a sense of where people stand before kind of getting into the conversation at large, I find is beneficial. So I generally inquire for the patient to provide information in their own words, sort of what their sense of where things are at, and maybe potentially what some of the treatment options that have been suggested to them have been. Thereafter, I generally want to get a sense of what they're hoping to gain out of the consultation, whether it's just a second opinion such that they can go back to their other oncologist, or if they live a number of hours away, they can go back and get treated locally, or if they're interested in clinical trials, for example. And once we kind of have those as parameters to sort of frame and sort of set the tone for the consultation, I then generally walk patients through sort of what is prostate cancer, the fact that it as a disease is exquisitely generally dependent on testosterone in terms of fueling it, in terms of cell division, growth, spread, and all the other sorts of nasty things that prostate cancer likes to do, and that by cutting off the supply of testosterone, that's sort of our first and foremost strategy in terms of getting the disease under control. I want to make sure that it's well understood that by doing so, yes, we might be able to kill off some of those cells, but the vast majority tend to just go into a state of dormancy or hibernation, and so we're not able to cure people. And I think it is important to sort of make that known, and depending on the comfort level, one can sort of get into what the prognosis might look like, or leave it be. And then thereafter, I state that, based on some of the data that we've talked about, that treatment intensification pretty much would be mandated, but that, that could take the form of either further, hormone pills, basically, abiraterone or enzalutamide, or chemotherapy, and sort of lightly touch on the pros and cons of both. Oftentimes, I will then provide them with, patient-facing information on the drugs and sort of the typical side effects, such that they can read about it on their own time and get a little bit familiar in terms of what the side effect profile of the different drugs might look like. But basically then say we'll defer that conversation to when I see them again in a month's time. I generally like to get people up and on to androgen deprivation for at least a month or so prior to talking about implementing next steps in terms of intensifying treatment, just because it's a lot going on. Dropping someone's testosterone from normal levels to castrate levels definitely wreaks havoc on the body, and sort of there's a lot to adjust to, and so there's no main gain or advantage to sort of rushing into your next step. And so given most of the trials allowed for a few months before starting chemotherapy or a novel AR based therapy, I do allow that kind of leeway to allow people to get kind of adjusted, acclimatized, and then they can think about sort of what their next step might be. And then if there are any other housekeeping issues, such as ensuring that they have calcium and vitamin D supplementation, acknowledging that long-term androgen deprivation can put a person at risk for osteopenia, osteoporosis, and fractures, I think that's important to sort of convey as well. And then lastly, if they meet the criteria for potential discussion with a genetic counselor, either if they present with de novo upfront metastatic disease, or if they previously had a history of high risk or very high risk localized prostate cancer, irrespective of what the family history might look like for suggesting a hereditary cancer syndrome, I do put it out there that it might be worth their meeting with the genetic counselor, specifically if they have other family members or children where if there is a germline heritable process ongoing, it could potentially have an impact down the road. And if they're open to that, then that's sort of a sidebar issue that can be explored. They can see the genetic counselor and go through the pros and cons of germline testing and take it from there. But that's my general sort of approach to my initial consultations for a patient with newly diagnosed metastatic prostate cancer.